Welcome to Forum at 360. I'm Andrew Kitchenman. Today on Forum at 360, we'll talk about why healthcare in Alaska is so expensive. Alaska had the highest level of healthcare spending of any state in 2014, the most recent year with available information. These costs affect individuals, families, and employers. They lead Alaskans to seek care out of the state, and they have contributed to there being only one insurer on the state's individual and family market. Our guests will give their perspectives on what is driving these costs. They'll also talk about what's being done to try to bend the upward curve of healthcare costs downward. These efforts range from small-scale pilot programs to one of our guests making repeated trips to Washington, D.C. to testify before Congress. That person is Lori Wing-Heier. She is the director of the Alaska Division of Insurance. She has 30 years of experience in the insurance industry, including working as a broker and agent. She's worked with state legislators and members of Congress to launch the Alaska Reinsurance Program. Health policymakers across the country have turned to Alaska to learn about the program. Beth Johnson is the Senior Vice President of Healthcare Services for Premera Blue Cross Blue Shield. She oversees the contracts Premera negotiates with providers and manages the insurer's network of providers. She has more than 25 years of experience in the health insurance industry. And Becky Hultberg is the CEO of the Alaska State Hospital and Nursing Home Association. She previously served as commissioner of the Alaska Department of Administration in Governor Sean Parnell's administration. Her association includes acute care hospitals, behavioral health facilities, assisted living facilities like the Alaska Pioneer Homes, and nursing homes. We'll start by asking Becky Hultberg and Beth Johnson about what they see as the chief drivers of Alaska's high healthcare costs. Then we'll ask Lori Wing-Heier to talk about what her division has been doing to make the individual market work and other insurance-related issues that she's focused on. Then I'll ask questions and we'll take questions from the audience. Please welcome Lori Wing-Heier, Beth Johnson, and Becky Hultberg. Thank you. Okay, so Becky, what do you see as driving healthcare costs?
Well, Andrew, first of all, thank you for inviting me here to talk about to answer such a simple question, right? Because healthcare is probably one of the more complex industries that anyone would ever study, and there's not a simple answer to this very complicated question. So a couple of points. First of all, there's not a state in the country that has really figured this out. We're all in different stages of working on how to address healthcare cost growth. I think that's kind of the second point I wanted to make is we're talking about absolute costs, like why Alaska's costs are so high. But the real key moving forward is how do we manage the rate of growth? Because if we lowered our costs but grow at the same rate, we're going to end up right back where we are today. So the real success for us will be when our healthcare costs are growing closer to the rate of inflation. So all that said, what are some of the drivers? Well, I'm going to list a few. These are just probably the tip of the iceberg on some of the complicated factors driving healthcare. But some of them you may not really expect or have thought about. Our system of employer-sponsored healthcare is one thing. And the tax treatment of healthcare. When healthcare is deductible, then there's an incentive for companies to offer $1 in health benefits as opposed to $1 in wages. And so that really has driven more expensive healthcare plans. Third-party payment, which means that most of us pay the full cost of our health care. And when price is normally in a market system kind of how things are allocated, that mechanism doesn't really work effectively in healthcare.
It's because the person who's buying insurance, the person who's receiving the services isn't the same person.
Well, and how many of us think differently if we've met our deductible and out-of-pocket max about what services we're going to buy? We tend to buy more when we're not, or consume more when we're not paying for it. So when you hit that level, consumption and the thoughts about how much you consume change. So another element in our system is high administrative costs. We have the system that involves employers, providers, insurers. Insurance billing alone is a significant administrative cost, whether it's a public payer or private payer. A couple other quick factors, and I'll not monopolize this part of the conversation. High cost of prescription drugs, our utilization of medical technology. We utilize medical technology like CT scans at a far greater rate than most industrialized countries. Higher provider rates. We do have higher provider rates than many other industrialized countries. An aging population, unhealthy lifestyles, social determinants of health. Your income level, your marital status, whether you have housing or not, all of those things drive healthcare costs. And then finally, culture and expectations. We have some different spending patterns in this country than they do elsewhere. We spend a lot more at the end of life. We are not accustomed to waiting for things. We in some countries that spend much less, you might have to wait for a procedure, and that's not part of our culture. So culture and expectations is another thing that actually contributes to our healthcare costs.
And what do you see as unique to Alaska?
So I think Alaska does have a more concentrated provider market. We're just a little behind the times. I mean, when I look at our not in terms of our technology or our providers, we have great technology, excellent providers, but just in terms of the evolution of our market, we have not moved into value-based purchasing like they have in some other markets. So I think I just view us as being behind the evolution. We've not followed the same evolution as other markets, and I think we will, but it's not quite caught. Those same trends we're seeing in the lower 48 that are helping to moderate costs just we've not quite seen those here yet.
And value-based purchasing.
I'm sorry, I'm using industry buzzwords.
That's okay, I'll stop.
So it's back to the fee-for-service system is what we have today, which incentivizes the volume of procedures. Providers get paid based on how many things they do, how many things they do to people, right? And value-based purchasing is really purchasing focused more on outcomes than on individual transactions. And that really is a system that aligns the financial and the quality interests of providers and payers and patients better than in a fee-for-service system, which is strictly reimbursement based on volume.
Thank you, Becky. Beth, what do you see as the big drivers?
Yeah, no, thank you, Andrew. And like Becky, thank you for inviting Premera to participate in this conversation. Premera has been in the marketplace here for over 60 years, and with a multi-state presence, we have the perspective to bring from a multi-state. Becky very astutely and eloquently spoke to many of the factors that are impacting the overall cost of care. It's a fee-for-service environment, and so providers are incentivized. The more they do, the more they get reimbursed. And providers in Alaska are challenged by the geography of the state, the distribution of the population. We've seen heroic actions of providers and hospitals to care for the citizens of Alaska. And they're faced with challenges that other markets aren't faced with challenging. So it is, in general, the fee-for-service market and the fee-for-service reimbursement structure that tends to drive up the costs. I agree very much with Becky on the technologies and procedures and the pharmaceutical advances that we're seeing, which again are very conducive to life, but also drive up the cost of care quite exponentially. So as far as specific to Alaska, we spoke about the geography and the population. There are certainly those social determinants of health where factor into someone's healthcare and the cost of that healthcare. I think what we've also seen in Alaska is just a difference in how providers have been reimbursed over time. In the lower 48, there's more of a fee schedule in place. In Alaska, most of the contracts have historically been at some type of percentage of charges, and that has probably added to the exponential growth of the cost in Alaska versus other markets.
Okay, and was there anything that you wanted to add from your perspective?
No, I agree with what both Becky and Beth have said as far as the cost drivers. We're a large state. We have limited provider competition. We all want service today, and it is kind of become a culture. I speak to it sometimes. It's going to take a generation to change the way we access healthcare and the way we determine how we should pay for it.
Okay, so you're faced with a pretty big task in overseeing the regulation of the individual and family market in Alaska. It's been pretty challenging. Could you talk about the work that you've been doing in this area?
Well, 2017 has certainly been busy for us. In 2016, we worked with Governor Walker to pass HB 374, which established the reinsurance program. The reason we did that was because we knew we were at a crisis point as far as insurers in the state of Alaska available in the individual market. The bill passed with bipartisan support overwhelmingly, but then the work kind of began, because in the message of the legislature supporting the bill, they also said you basically have 2 years to fund this long term. We knew it would have an immediate impact on the individual market, and it did. While it was still a rate increase, in 2017 we saw a 7% rate increase, where the prior 2 years we had seen close to 40%. So the reinsurance program was done. We're now facing how do we fund it long term. In January, we applied for an innovation waiver to the federal government, CMS and the Department of Treasury, IRS. That is not a simple process, I can tell you, but through a lot of negotiating, a lot of FaceTime. In July, Governor Walker received a letter saying that the waiver had been approved. That establishes 5 years of funding for our reinsurance program. That, knowing that it was going to be funded going forward in 2018, along with other factors, I think Medicaid expansion, perhaps we are starting to look a little bit at how we access health care. We are seeing a drop in rates this year. We're projecting over 20%. If Washington funds the CSRs, it's going to be 26.5% in the individual market. That's huge for us. So we are
CSRs
are cost sharing reductions that are for low and moderate income. They're out-of-pocket expenses. If those are not funded, the cost basically gets spread across the rest of the market, or to the insurer, meaning that the rate decrease would not be as significant, or not as much, I should say, as it would be if the CSRs are funded in 2018. So we think we've made great steps, but we also recognize that there needs to be a conversation on the cost of health care, and I think that has started. But I don't think that any of us should expect there's going to be an immediate solution, regardless of who's leading the charge. It's going to take the administration, legislators, providers, consumers, insurers to figure out exactly what we're willing to pay, because what we're willing to pay for determines what we have in medical providers. And so it's going to be a long-term process, and that's kind of, we're involved in that, but we're also very closely monitoring what's going on in DC right now as far as the efforts to amend the Affordable Care Act and the impacts that would have on Alaska.
What you just described, how it's going to be a long-term effort and there's so many different players, it's been, Alaska's had high healthcare costs for a long time. Do you have any sense as to what it's going to take to make a change happen in the future that hasn't happened up until this point in time?
I don't know that I do. I think that, as I said, the conversations have started. I think that all of us are going to have to give a little. Our expectations of what healthcare is, as Becky's, the immediate, we need the best technology and we need it right now, as opposed to, if I waited 3 weeks, what's the difference in cost? ER services are much more than if you access through your primary care. And yet we sometimes go to ER when perhaps it could wait for primary care. It's kind of a cultural mindset. We want it right now. We're an instant gratification society right now. And we want instant gratification when we have a pain or an instant diagnosis. That tends to lead to higher healthcare costs. I just think that the conversations for consumers, I think the conversation with insurers of how do we structure with providers payment, the fee for services versus value-based. If we look at the whole person and the end result, as opposed to jumping on an assembly line to get every test you can have done known to man, for them to come back and say, yeah, it's really nothing. And I think there's a lot of regulations that we've heard from providers and insurers that could probably be looked at again to see if they really bring anything good to the table coming from DC, that perhaps we can get the administrative costs down, if there's any value.
Thank you. I wanted to ask about a state regulation. The state has a rule called it's popularly known as the 80th percentile rule, and it requires that providers be paid at least as much as the amount that 4 out of 5 providers charge for their services. A little complicated, but basically it's based on charges. And analysts say that this can lead to providers naming their price that insurers are required to pay. Is the state looking at that rule, and do you have anything you want to add about the 80th percentile rule that the public should know about?
Well, we held 2 hearings in January on this, and we had, the rooms were packed, and we had 60-some letters of pro and cons on the 80th percentile. We keep going back to, this is a consumer protection, and the other question is, are providers using the rule to set their rates? I have yet to have an insurer come to me and say, if the 80th percentile goes away, we'll drop our rates 4%, 10%, 20%. What I do have is consumers calling saying, I'm paying $2,500 a month for a premium, I've got a $7,500 deductible, I've got a co-share, and if you don't pay at the 80th percentile, if there's not some agreement for out-of-network services, I have a huge balance bill and I can't afford it. So I can't afford to get medical care.
And it's a consumer protection because by requiring, it sort of draws the insurer in and sets a framework for how much providers are going to be compensated so that the entire bill isn't, or a huge amount of the bill isn't shifted onto the consumer.
It is, but I think it's important to remember that this is out-of-network providers, and that in the big scheme, this is a very limited number of providers in the state of Alaska. So in changing the regulation, we're painting every provider with the same brush that we're also painting a very few specialists that we believe may be raising their fees or charging a fee that is driving the 80th percentile.
Beth, do you have any thoughts on the 80th percentile rule?
I do, and thank you for asking. I'd like to go back, though, if I could, to build on some of what Lori was saying before about how we need to work together to come to solutions to bring the cost of healthcare down in Alaska. Because I think that's absolutely true. That we've had great collaboration with the Department of Insurance to be able to stay in the market as the only carrier to serve the individual population. We have great relationships with many of our hospitals. Becky and I were talking just before we started taping about the inroads that Foundation Health is making in Fairbanks and the infrastructure and the commitment that they have to the people of Fairbanks as they're bringing in. We are working very differently with our providers in both Washington and Alaska in trying to find those common ways that we can serve the customer. We like to say at Premera that there's 4 problems that we're trying to solve. One of them being that we want to make sure our members are not getting care that they don't need. And so that is if they have an x-ray or a diagnostic service that isn't going to help them, let's make sure they don't get that, or do the watchful waiting for the physical therapy or those types of services. But just as much, we want to make sure that our customers, the citizens of Alaska, are getting the care that they need. There's a need for primary care, and as we are working to put incentive-based agreements in with our providers, we are very much highlighting the components of getting preventative exams and preventative screenings as a way to engage our providers differently and make them accountable for that cost of care. The customer experience is also becoming much more important as we do that. And finally, cost. It has to be affordable and have that high quality. And cost is a big conundrum in the state of Alaska, and we spoke to some of the reasons for that. What we do see is for some of the common services, and I think it gets to our challenges with the premium levels and the the costs for employers in this marketplace is just how the reimbursement in Alaska is different than in the lower 48. And there are some differences, as I mentioned, because a lot of what has occurred in Alaska has been based on percentage charges, 80th percentile or not. That's just how the reimbursement has arrived. And we get to the cost of living in Alaska is about 20% or so different than in the lower 48 in general. Medicare, the largest payer in the country, recognizes that difference and pays providers on average in Alaska about 25% more than they pay the lower 48. What we see in the commercial market, though, is a much greater difference than that. For certain services, like mainly professional services I'm speaking about, for an ER visit can cost about $1,000 in Alaska. We did a study on several different cities, Seattle, LA, San Francisco, Chicago, New York, Washington, DC, and others. And the range for ER visits are between $200 and $300 in the lower 48 and $1,000 in Alaska. Knee replacements are on the order of $7,000 in Alaska and $2,000 to $3,000 in the lower 48. Colonoscopies with a biopsy, something everyone over 50 should have a colonoscopy, it's about $1,500 compared to $400 to $600. And then MRIs, $2,000 versus about $500 in the lower 48. And then when you get to procedures like a heart valve replacement, which is very serious, and we want to support those happening in Alaska, the cost can be $34,000 in Alaska and $4,000 in the lower 48. So we've got to figure out, no one is suggesting that the cost in Alaska needs to be what the cost in the lower 48 is, because we have those unique challenges that we just talked about. But I think to Lori's point, it's going to take regulators, it's going to take the hospitals, it's going to take the providers, and it's going to take the carriers to come, and the customers, to come to a solution for how do we move forward to make sense of a rational pricing in Alaska.
And I actually saw recently the head of the, we don't have a representative of the Medical Association, but the head of the American Medical Association in Washington said at a conference that the AMA really won't support limits on pharmaceutical prices because it would open them up to reductions in provider to prices, the prices that they're paid. Is that a problem, that if each piece of the system has its own interests and doesn't want to be the first to go in and give up something?
You know, I can't speak specifically to that, but what I would say is that Premera has seen a change in the willingness of providers to have different conversations with us, the same as the willingness of Premera to have different conversations with the providers. So Becky was speaking about the value-based agreements. There's a lot of infrastructure that providers need to put into place to be able to track their patients, to make sure, as I mentioned, they're getting the care they need. They might need to have registries in their offices to track, you know, who is a diabetic and how do they want to interact with that diabetes. And so it takes time to change, as Lori was saying. But we feel a willingness and a desire of the providers to partner. We just have a long road ahead of us on how we're going to do that and how quickly that can happen in the environment that has been created decades ago that we're going to need to continue to plow through.
Does Premera have a position on the 80th percentile rule?
We do. We have a position that we think it should be revisited. We were at the director's hearings in January, and so we have both written and verbal records. You know, the DOI has a real responsibility around consumer protection, and it absolutely had a time in its day to make sure we could recruit providers into Alaska, to make sure that providers were getting adequately reimbursed. Now I would suggest providers are more than adequately reimbursed, and maybe we need to take a look at what is the consumer protection we want to do. The commissioner has, or excuse me, the director has been very open in the conversations she's had with Premera and other carriers and other constituencies to forge that common path to move forward. So we've been encouraged by the dialogue and encouraged by the participation of the various constituents in that.
Is there anything, listening to what the other panelists are saying, is there anything you want to add? Not necessarily about the 80th percentile rule, but some of the other points that have been made.
I think I would reiterate a couple of things that the previous two panelists said. The first is that it's taken us a long time to get here, and it's going to take us some time to change. So this system that we've created in the United States was a system really that has its foundation in World War II and employer-based insurance. And our particular cost escalation in Alaska was also not something that has happened in the last 2 years. So it's taken time for us to get here. It's going to take us time to change course. I think the other thing I would caution us all is that there's not a silver bullet to this problem. There are, as we talked about before, many different complex reasons that healthcare is expensive, and there's not one thing that we can do that is going to change the trajectory. And so, from a provider standpoint, from a hospital-based provider standpoint, I think our approach is going to be to partner rather than point fingers, because I think we're going to go a lot farther, a lot faster if we're working together rather than trying to say, well, you need to do X and you need to do Y, and I don't need to do anything, it's someone else's problem. Mm-hmm. And so that's the approach that we want to take as a partnership approach.
Mm-hmm.
Okay. A couple of our producers paid a visit this week to a Juneau man who buys his insurance on the individual market. He shared a little bit about his situation and has a question for the panel. Let's take a look.
I'm Ben Disney. I'm the owner of Zentropa Services. It's a general contracting business. I'm a self-employed individual with subsidized premiums from the government with incredible deductible costs and very high out-of-pocket expenses. And so I find myself, if anything happens, almost unable to afford it. I find myself in a constant balancing act of what I'm allowed to make. I have to find a way to not make more money than they'll change my subsidy rating. And I never know. I never know what it's going to be. It's up in the air. How am I going to have a good season? Am I going to have a good year? Am I going to have a bad month here? Or how am I supposed to figure out what I'm going to end up owing? And I can't even get answers out of doctors what I might end up owing. My biggest issue is that I have health insurance, and I'm scared to go to the doctor just like I was when I didn't have health insurance, because I don't know if I'll be able to afford it. I feel like there's a lot of benefit to this Affordable Care Act. I just think it's bent. I think there's not enough balance in it. I want to know why I'm the only one mandated to do it. You're not mandating the provider to negotiate with the insurance company. You're not mandating the insurance company to pay what they don't agree to pay. And I'm just wondering how that's okay when I only have one choice of a provider in the state as an individual.
We've been using the word provider to refer to healthcare providers like doctors and hospitals, but he's using it to refer to insurance providers or insurance companies. I guess, well, I'll start with you, Lori. Are you familiar with these type of concerns? Do you hear them from Alaskans? And what were you thinking as you heard him talk?
Well, we do hear these concerns. I wouldn't say we hear them every day, but generally the overall sentiment is very much as he has expressed. The good thing about the Affordable Care Act is that people that were not able to access insurance before because of pre-existing conditions now can. And they instituted the premium tax credits and the cost sharing reductions to help low to moderate income afford it. However, there are some unintended consequences that we're still trying to work through. One of them I think he hit on of if he makes too much money on a given day, then he still doesn't make enough to really pay his premium, but he doesn't get the tax credits or the subsidies. And it's a balancing act for families if I work that overtime, or accept an additional or a new position, now I've taken myself out of the market. I can't afford it. So we don't want to stifle people's careers or what they can earn simply because if they make another $50 and the cliffs are that sharp, that they don't get a subsidy. I think also he brings up a point on the deductibles. I mean, this is kind of what we were talking about on what the insurance company will then reimburse for. You've got copays, you've got deductibles, you've got premium, and you have a potential balance bill. And there are consumers that are saying, I'm paying the premium, but I can't afford to get the health care. And so we're trying to work on how do you bring that down so that the deductibles are reasonable or the premiums are reasonable, but that half of their income isn't going, or more is going to health care, that they feel like they can't take care of themselves because they can't afford it monetarily.
So Mr. Disney, I should say, is an active KTOO member. He's also would be a customer of Premera.
Sure.
So what are your thoughts on the concerns he's raising?
Well, a couple things. One, I would encourage Mr. Disney to reach out to me or to Premera directly, because we do have tools that our customer service representatives and our web tools can help answer some of his questions. A couple of other comments there is we are mandated. Premera is very much mandated and regulated in what types of plans that we can offer on the exchange. And so we are under a lot of regulation and mandates on what we can do. And it's a balance between the premium levels and the deductibles of what we offer in the marketplace. Premera has been in the individual and small group market in Alaska since the inception of the ACA and prior to the ACA. And it is a volatile market. There's about 20,000 lives that are in there. And we're constantly looking at how we can balance and rebalance, how we look at the benefit structure to make it more affordable to individuals. And any year, given the population, if there's a couple of high utilizers that utilize the expensive services I just went through, it swings the cost one way, and so premiums go up. If we have some less, it swings it down. And so every year, as Lori mentioned, we are filing different premiums. And with Lori's and the state's assistance around the House bill, with the reinsurance, we are able to offer a premium reduction this year. So it's again, for 2018, it is that balancing and rebalancing of how we do that. So mainly it's, yes, we do also have mandates just like Mr. Disney, and very much welcome the opportunity to have Mr. Disney reach out or provide his information if it's agreeable to him, and we can help him with some tools and information to answer a lot of his questions.
Do you have any thoughts on this?
Sure. I think he really highlighted that there are problems, and there were problems from the beginning with the Affordable Care Act. This was an act that associations like mine supported and continue to support today because it expanded access to insurance coverage. It provided a way for individuals with pre-existing conditions to purchase coverage who could not in the individual market before. So there were so many benefits and positive things about the act, but no major piece of legislation is perfect, and this one certainly wasn't either. But it's been a really difficult dialogue to have. How can we fix some of these unintended consequences? We really haven't had that conversation in a really deep way in this country yet. And I hope that we are getting to a point where we can, because there likely are changes that need to be made to address some of the concerns that he raised and that people have experienced. And we hope that we can start having that conversation instead of this sort of repeal, replace conversation. Not that I really want to get into that whole issue, that's not the subject of this show. But he raised legitimate concerns that should be addressed.
Okay, we'd welcome questions from the audience. There's a microphone. Employers bear much of the rising healthcare costs, and when they pay more for premiums, it can squeeze out pay raises for their workers. What's your message to employers who are looking to reduce costs? I'll start with you, Becky.
I think you said that employers bear much of the burden, and they do bear a great percentage of the burden. But there is some research that shows that actually employees are bearing a larger and larger share of that increased cost. So it is yes, for employers, health insurance is a growing cost, but one of the things that we're seeing is people, as this gentleman mentioned, who are increasingly unable to afford care up to the point of their deductible. So I think it is an issue for employers, but it is also, employers have had to begin cost shifting to individuals, so this is becoming a bigger and bigger issue for individuals as well.
Do you see if more and more Alaskans reach if deductibles continue to become more important and more Alaskans reach their limit as far as how much they can pay, how much they can pay, how much money they have, do you think that could spur political reaction in the legislature and the administration?
I think you're seeing a little bit of that already. I mean, we're having conversations about health care in this state that we would not have had 5 years ago. And I think that's actually a healthy dialogue for us to be having. So could this spur change? Again, there's not one silver bullet fix for this issue. There's not one thing that we can do to address it. But is this a necessary conversation between employers, providers, and insurers and policymakers? Absolutely, it's a necessary conversation. The solutions are not going to be easy, and so we're going to have some patience as we all try to work out how we address this very complex problem.
Thank you. Beth, do you have?
Yeah, actually, it's a very interesting question because there are impacts to the employer groups. In Alaska, Premera has insured business that we are regulated by the Department of Insurance, but about half of our business is for employers who are self-funded. So they are not subject to insurance regulation. And they very much want to be able to give pay raises and give other things, but some of their healthcare spending crowds that out. We have an example of an employer locally in Anchorage, an auto dealership, who is a self-funded employer, and more than a dozen years ago had no cost share for their employees, had no deductibles for their employees, and their healthcare costs were $400,000. Fast forward, again, more than a dozen years, so there's a period of time where their healthcare costs have skyrocketed to $1.7 million. And they have deductibles, $1,000 or $2,000 deductibles for their employees. And so we have seen that employee cost, we've seen that employer costs. So particularly on the self-funded side, where they have a greater degree of discretion on how they administer their benefits, we've seen some of those employers choose to reimburse non-contracted providers at 125% of Medicare. This is different than what the contracted amounts are in Alaska, are 400 to sometimes 1,000% of Medicare. What they're also doing is sending more, unfortunately, of the healthcare services out of Alaska to get some of that cost relief. And so we're seeing an uptick in our travel benefits and employers wanting to buy those travel benefits to have more affordable care by exporting it from Alaska. That's not a good thing. If someone's sick or needs care, they don't want to move out that care out of state. But we're seeing, as employers are looking at what are their options to reduce their healthcare costs, they're left with some difficult choices to make. And so those are some that we see that they're making.
We do have a question from the audience. If you could identify yourself, and if you have a specific person you want to direct the question to, if you could indicate that person.
Okay, hi. My name is Clayton Hamilton, and I'll give this to Becky. You've all told us that healthcare is more expensive here, but I knew that. But without finding a silver bullet, why is a heart surgery twice as much here as it is in Australia, and why is my CT scan more here than it would be in Iowa?
So again, I can't really point to one single reason why, but I think one thing I wanted to make sure is clear is under a fee-for-service environment, you don't just have one price for a procedure. You have a facility fee, which is the hospital price. You have multiple physician fees billed individually for the anesthesiologist, the heart surgeon, and if some other specialist was called in. You might have lab fees billed separately. So it's really hard when we're having this conversation about a price to know, was it the facility fee that we're talking about that was the big difference? Was it the physician fee that was the big difference? Because I think that's relevant as we begin talking about some of these issues. I'll just use our small hospitals as an example, and I consider that we're in Juneau right now. Bartlett is in Alaska a medium-sized hospital, but anywhere else would be considered a small hospital. Hospitals, in a way, are kind of like public utilities. They have to be on all the time. You always have to be ready to see patients in your emergency department, and you have really high fixed costs that you have to cover of staffing, of equipment. So, for the small hospital example, sometimes those costs are going to be higher in a community like this because you have to do everything here. You have to have the ability to stabilize a trauma patient so that you can get them on a medevac. And those fixed costs are simply going to be higher. But again, without talking about specifically which component of that cost we're referring to, it's really hard to make a generalization about why the total cost of care was more expensive.
And do you have anything that you want to add, Beth?
No, I think that covers it.
Okay. We just talked about how Alaskans are flying out of state sometimes to receive health care. How important is it for people inside the state to reduce that? And is anything going on right now that may push that trend downward? I don't know if that's something the division ever looks at, but
we know that there's been an emphasis on large employers and small employers, and even individuals who basically look at pre-pricing what their procedure is going to be, to go out of state if they think they can have the procedure accomplished at a lesser rate or a lesser fee. But we're also cognizant of the fact that we all want to be able to have the service locally. Nobody wants to have to go outside. Now, certainly in certain instances, you're going to find somebody who has a very serious illness that no matter where you are, you're probably going to go somewhere else to have it treated because there's a specialist in Cleveland or there's a specialist at Mayo. And we will never have that ability in Alaska because we're too small to have a specialist that only does this one thing. So there's that example of when you really think you need to go, but we don't want to, we're trying not to get to a point where we're recommending that you always go outside. One, it's going to lessen the impact of our medical community here. We're going to have fewer providers if everyone's going outside. And you also have the issue of follow-up. If you go outside to have a procedure done, how do you keep the relationship going with the specialist or your primary care in Alaska who did not provide the procedure or the recommendation that you have the procedure? So there's things to be looked at before going outside for treatment. It's not to say that sometimes you shouldn't. It's not to say that sometimes it's less expensive. I think the issue is that we've all been discussing is getting where we aren't the highest cost of health care, that we look at how we pay and how we utilize it.
The state released a study it had commissioned in August, or released it in August, on the idea of forming a healthcare authority. An authority would basically offer a common set of health plans to groups like state workers and retirees. The report said that the state could save more than $100 million if it made some changes in healthcare, maybe not necessarily directly related to forming an authority. I imagine you've all looked at the report. Becky, what's your thoughts on this healthcare authority study, or really series of studies?
It's a really long report, and I did read it. But I think it's actually a series of four reports from 3 different contractors, and they're experts in the audience, and I'm not one of them. So, but I'll do my best at kind of outlining some of the discussion points that this report will raise. I think the authority structure is really a mechanism. It's a tool. It's a way to organize how the state administers its healthcare plans. But I think we have a long way to go in the policy conversation about, is this a tool that should be implemented now? If so, how should it be implemented? And which groups of employees should participate? Part of the report also talks about purchasing strategies that aren't necessarily aren't necessarily linked to the establishment of an authority, but could be used. So really, when you're talking about this study, you're talking about, again, 4 different studies that kind of address different issues, each of which is going to, I think, raise some really interesting conversations at the state level.
Any thoughts on these studies, Director?
I don't know that I have anything to add to what Becky said. It's a process. It brought some ideas to the state that may bring value, but at this time it's in its infancy to really see where this study goes.
And how about you, Beth?
We're still assessing, so
Okay.
same perspective.
Fair enough. Lori Wing-Heier, I wanted to ask you about the future. What's the division working on right now?
Well, we're certainly looking into the future to see how the individual market and the small group market that we regulate, what they look like in 2020, 2021. Our waivers for a 5-year period. We expect that there will be changes coming on the Affordable Care Act, and how do we take those changes and make the best available products to Alaska as far as insurance being a product. It's a highly regulated industry. We have not just state regulation, but we have federal regulation. And so depending on this push-pull right now that is going on in DC, our market could change. Some of the bills talk about taking away the funding for the premium tax credits. Some say the individual mandate. Some say we should change the essential health benefits. So we're keeping on top of it. We're spending a lot of time looking at proposed draft bills or amendments to the Affordable Care Act to decide or to determine what the impact is to Alaska. Is it good, bad? Is it something we can live with? Is it going to reduce costs? Is it going to make it more accessible, more affordable? How does it impact Alaska as we go forward?
Is it hard to do your job right now with that amount of uncertainty?
I don't think it's hard. I've got a great staff. I mean, I'm really blessed in that I have a great staff, but we're busy. I will tell you that.
I know the administration's decreased the amount of time that individuals will have to sign up for individual or family health insurance this year. It was 3 months last year. That's the open enrollment period for the ACA plans. Is that going to be a challenge for Premera to
If I could just interject, that's not the Governor Walker's administration.
Yes,
That is
I'm
the
sorry,
federal
President
administration
Trump's
that,
administration,
did
yes,
that.
the
I
federal
wanna be clear on that.
administration. Is that going to be a challenge for Premera to keep that pool of insured people in Alaska?
No, it won't be. We would certainly prefer that people have a greater opportunity to enroll, but certainly we're prepared for that time frame. So there's no difficulty in administering that.
Okay, it looks like we have another question coming from the audience. So if you could identify yourself and direct your question.
My name is Brenda Taylor, and I appreciate the forum. I'm curious about how we bring doctors into this conversation, because I noticed there aren't any doctors up there. And I know we've been talking about providers, and sometimes that means hospitals, and sometimes it's implying doctors, and just kind of...
Yeah, so basically, this is the second forum that we've had on healthcare this fall, and we may have another, and we're basically seeking to have balance across all of the forums that we're holding, but because of the limited time, we think it's more beneficial to hear more in depth from a limited number of panelists rather than to have a really large panel where each person doesn't have a lot of time to talk. So that was basically my call, and so that's basically the explanation for that. Is there anything that we haven't talked about that you think it's important for Alaskans to know?
Well, I think there's, first of all, I think that the previous questioner made a good point, and that is that all of us in the provider community need to be at this table together. And I think there are some really good examples of positive things happening that, we've talked a lot about the bad, the how high costs are, and how it's going to be hard to address it. But I think there are some really good things happening in the market, and we should be highlighting that too. Hospitals are voluntarily working on a couple of initiatives. We are working on an emergency department project that is linking all of our emergency departments together electronically, so that if someone is in the emergency department in one hospital one day and in another one the next day, there's a really easy way for that emergency department physician to understand and to know what was going on. That's a really overly simplified description. We're also working on voluntary quality improvement efforts. So I think it's important that we highlight some of the positive things that are happening in the market as well. And I know, Premera has initiatives with physicians that are, I think, a good example of new kinds of partnerships as well.
Okay, we received a question, and it was in 2016, the legislature passed a bill requiring healthcare insurers in Alaska to offer plans that cover certain mental health services via telemedicine. It was expected to reduce costs and improve access for patients. Is that working as expected? Have there been problems with implementation?
I don't know that I can address the implementation. I'm not aware of any problems with the implementation, but the bill just passed. So we would have 3 or 4 months worth of data really to say how it's impacting Alaska, either in a good way or a negative way. Anytime we have a mandate or a change, it takes time. The policy plans, that would have gone into effect for the 2017 plans. It's October, so we're just, if there is a positive impact to it, we probably won't know until July of 2018 when the 2017 plan year closes out and we can see the impact.
We have another question from the audience.
Yes, Ray Pastorino. I've listened to you all and heard a lot about how complicated this system is. Also about how expensive it is and how high the administrative costs are. I'm aware that out of the 25 industrial countries in the world, we're ranked 25th in terms of cost. In other words, we have the highest costs in the world for what we do. And if we consider Alaska being the highest of the highest, then that's a fairly large number. And I'm wondering whether there should be serious consideration, rather than constantly struggling with the market, with consideration of a single payer system, and what your thoughts are about this. Perhaps it is time to consider that for all citizens. Wondering what your thoughts are on this.
I don't know, Beth, if you want to take this.
Am I the obvious choice? Certainly there's advocates for single payers, and I don't know that a single payer will address all of the conversations and all of the challenges. Some of what Premera is very focused on is investment, in investing in the types of tools that will make healthcare work better. Our purpose is to improve customers' lives by making healthcare work better. And making healthcare work better is going to take some investment. It's going to take some investment in working with providers differently so that they're focused on those preventive services and not the fee-for-service, high revenue services, and change that paradigm. To put that infrastructure in place, as Becky and I were talking about specifically in Fairbanks, it takes some infrastructure and things. I'm not sure who would pay for that infrastructure in a single payer system, but certainly there are constituents in Alaska and across the country that are exploring that as a potential answer.
One of the preventive services mentioned earlier was mental health services. Mm-hmm. Behind all of our physical maladies are behaviors. And but I don't know that our insurance rates value them or pay them at the same rate that they do for other services. If prevention really is a value that we have, mm-hmm. how can we better address it? What are your thoughts about that to make it happen?
Sure. There is a Mental Health Parity Act so that insurers are required to have the same level of benefit for behavioral health services as physical health services. So that is certainly an area that we all comply with. We very much look across our network of providers to make sure we have adequacy around all segments of providers. And as we look through and as we file our plans with the Department of Insurance, we have to show that we have network adequacy. And so we do have adequate network. We pay and reimburse at market or above market rates, certainly at rates higher than the lower 48. That's one of the categories. There isn't a category in Alaska that's paid less than the lower 48. They're all paid more than the lower 48. So I believe that it's being addressed.
That's all the time we have. We've been talking with Lori Wing-Heier, Beth Johnson, and Becky Hultberg. I'm Andrew Kitchenman. Thanks for joining us on Forum at 360.
Funding for Forum at 360 comes from Rainbow Foods of Juneau.